For years, we've taught our fellows the same thing. Stage 4 lung cancer and lung transplantation simply don't go together. It's been one of those rules that felt almost absolute. So when I came across a new paper in JAMA this week, I'll admit, I assumed I already knew how it was going to end. I was wrong. This study doesn't prove we should start transplanting patients with stage 4 lung cancer. Not even close. But it does ask a question that would have sounded almost unreasonable just a few years ago. And whether you agree with the authors or not, I think it's a paper every pulmonologist should read. We'll also look at 2 remarkably consistent Phase 3 trials that may change the treatment landscape for idiopathic pulmonary fibrosis. And finally, we'll spend a few minutes talking about nutrition in the ICU, because sometimes the best thing we can do is actually feed less. Medicine moves forward in different ways. Sometimes a study introduces a new drug. Sometimes it confirms something we already suspected. And sometimes it forces us to question an assumption we've accepted for decades. This week's papers do all 3. We'll start with one of the most controversial transplant studies I've seen in years. I'll admit, when I first saw the title of this paper, my initial reaction wasn't excitement. It was skepticism. Lung transplantation for stage 4 lung cancer? That sounds like exactly the kind of idea transplant physicians have spent decades trying to avoid. And honestly, for good reason. Historically, active lung cancer has been considered an absolute contraindication to lung transplantation. The concern has always been obvious. You're placing a patient on lifelong immunosuppression after removing a cancer that already demonstrated metastatic behavior. Intuitively, that sounds like a recipe for rapid recurrence. So why would anyone revisit that idea? Because not every patient labeled as stage 4 has the same biology. That's really the question this paper asks. The investigators focused on an exceptionally selected group of patients with non-small cell lung cancer whose disease remained confined entirely to the lungs. These weren't newly diagnosed patients. They had already exhausted guideline-directed systemic therapy, including targeted therapy, immunotherapy, chemotherapy, or clinical trials when appropriate. Despite all of that, their disease continued to progress, but importantly, comprehensive staging showed no evidence of extrapulmonary spread. That's a very different population from the stage 4 lung cancer patient we usually picture. The authors established a prospective registry and ultimately compared 3 groups: patients who underwent lung transplantation, similar transplant-eligible patients who could not receive a transplant because of non-biologic barriers, and a contemporary cohort of standard lung transplant recipients without cancer. One thing I really appreciated was that they didn't simply dust off historical transplant techniques. They also questioned whether the operation itself might contribute to tumor dissemination. To reduce that risk, they adopted what they describe as a dissemination-minimizing surgical strategy. That included early pulmonary vein control, bilateral pneumonectomy before implantation, and measures intended to reduce both hematogenous spread and airway contamination during surgery. Whether every component truly matters is difficult to prove, but I thought it reflected careful biological thinking rather than simply technical innovation. Now, let's talk about the results. They're striking. Early survival among the transplant recipients was dramatically better than among otherwise eligible patients who received medical therapy alone. Even more surprising, 1-year post-transplant survival compared favorably with the center's contemporary non-cancer transplant population. I'll admit, that caught me off guard. Not because I expected transplantation to fail technically, but because I expected occult biology to declare itself much sooner. Instead, the early outcomes were remarkably encouraging. Now, before we get carried away, this is where I think people could easily misinterpret the study. This is not evidence that lung transplantation should become standard treatment for stage 4 lung cancer. Far from it. Only a tiny number of patients actually underwent transplantation. This was a single-center experience. patient selection was extraordinarily rigorous. And perhaps most importantly, follow-up remains relatively short for a disease where recurrence may occur years later rather than months later. There are also broader questions that this study can't answer. Would these outcomes be reproducible outside an internationally recognized transplant program? Could less experienced centers achieve similar results? How durable are these outcomes at 5 or 10 years? And perhaps the hardest question of all, how should transplant programs balance organ stewardship when donor lungs remain such a scarce resource? Those aren't statistical questions. They're ethical questions. What I found most interesting wasn't actually the survival curves. It was what this study says about our understanding of cancer biology. For years, we've used stage as a surrogate for behavior. Most of the time, that's appropriate. But this paper reminds us that staging doesn't tell the entire biological story. Some patients with lung-limited disease may behave very differently from patients whose cancer has already demonstrated widespread metastatic potential. That doesn't mean staging is wrong. It means biology is often more nuanced than our classifications. I don't think this paper changes practice on Monday morning, but I do think it changes the conversation. In exceptionally selected patients with disease truly confined to the lungs after exhausting modern systemic therapy, automatic exclusion may deserve reconsideration. Let's switch gears. If the first paper challenged a surgical dogma, these next two studies may reshape how we think about medical therapy for idiopathic pulmonary fibrosis. And I think that's actually the story here. Not that one trial was positive, that two independent phase 3 trials were positive. Honestly, that's much harder to ignore. If you followed IPF over the past decade, you know we've become cautiously optimistic whenever a promising therapy emerges. We've seen encouraging phase 2 studies before, only to watch larger trials disappoint us. So when inhaled treprostinil first entered the conversation, I think most of us were interested, but skeptical. After all, treprostinil is a pulmonary hypertension drug. At least that's how most of us think about it. The excitement really started after the INCREASE trial, where investigators noticed something unexpected. Patients receiving inhaled treprostinil didn't just improve exercise capacity, they also appeared to lose lung function more slowly than expected. That observation wasn't the primary endpoint, but it raised an intriguing possibility. Maybe this drug was doing more than lowering pulmonary vascular resistance. Maybe it was influencing the fibrotic process itself. That hypothesis led to the TETON program. This week, we essentially have the complete picture. TETON 2 was published earlier this year, and now TETON 1 has been published alongside a pre-specified pooled analysis. The two trials enrolled nearly identical patients with idiopathic pulmonary fibrosis, used nearly identical protocols, and asked exactly the same clinical question. Does inhaled treprostinil slow disease progression over 1 year? One thing I really liked about these studies is that they weren't testing treprostinil against outdated care. Roughly 3/4 of patients were already receiving background antifibrotic therapy with either pirfenidone or nintedanib. In other words, this wasn't asking whether treprostinil is better than doing nothing. It was asking whether adding another therapy could provide additional benefit on top of contemporary treatment. And remarkably, both trials reached essentially the same conclusion. Patients treated with inhaled treprostinil experienced a significantly smaller decline in forced vital capacity over 52 weeks than those receiving placebo. Both studies also demonstrated fewer clinical worsening events, despite being conducted in different geographic populations. That consistency matters. In fact, I would argue it's the most important result in these papers. I'm less impressed by a single positive trial than I am by reproducibility. When two independently conducted phase 3 studies arrive at almost the same answer, my confidence changes much more than if one study had simply enrolled twice as many patients. Now, that doesn't mean every question has been answered. One thing that immediately caught my attention was the hierarchy of the secondary endpoints. Because there wasn't a statistically significant difference in acute exacerbations, The pre-specified statistical plan prevented formal inference for later secondary outcomes, including survival. That's important. It's tempting to look ahead and ask whether patients lived longer, but these trials weren't able to make a definitive claim about that. Another practical issue is tolerability. The most common adverse effect was cough, which admittedly isn't ideal in a population that often already struggles with chronic cough. Treatment discontinuation was also somewhat higher in the treprostinil groups. None of this is unexpected for an inhaled therapy, but it reminds us that efficacy alone doesn't determine success in the real world. A medication prescribed 4 times a day has to fit into patients' lives if we expect long-term adherence. And there's another question that these studies couldn't answer simply because of timing. The therapeutic landscape has changed rapidly. Many of us are now thinking about nerandomilast, combination therapy, sequencing strategies, and how multiple antifibrotic agents might eventually be used together. Treprostinil enters a very different treatment landscape than the one we had even a year ago. So I don't think the next debate will be whether the drug works. The evidence supporting its effect on lung function is now fairly convincing. The debate will be much more practical. Who should receive it first? Should we add it to existing antifibrotics? Should we reserve it for progressive disease? How much incremental benefit justifies another chronic therapy? Those are the questions we'll probably spend the next several years answering. One final thought. I think these studies subtly change how we think about IPF itself. For years, we viewed antifibrotic therapy through a fairly narrow lens. Slow fibrosis. That's the goal. Treprostinil reminds us that the biology of IPF is probably more interconnected than that. Vascular signaling, inflammation, fibroblast activity, and tissue remodeling don't exist in separate compartments. They influence each other. Whether prostacyclin signaling ultimately proves to be central or simply one useful therapeutic target remains uncertain, but I think these trials broaden our thinking about where future therapies may come from. For me, inhaled treprostinil has moved beyond being an interesting idea. 2 large phase 3 trials now provide consistent evidence that it slows the decline in lung function and reduces clinical worsening in patients with IPF. I wouldn't call every patient tomorrow and add another medication, but I will start thinking differently during clinic. For appropriate patients, particularly those already receiving standard antifibrotic therapy and continuing to progress, this has become a treatment option that deserves a serious discussion rather than a passing mention. Let's finish with something we do every day in the ICU. Nutrition. And honestly, I think we often make it more complicated than it needs to be. We calculate calorie targets, we debate protein doses, we worry that a patient is falling behind. Then we respond by trying to replace everything immediately. But here's the problem. During the first few days of critical illness, the body is not behaving like a healthy body that simply missed a few meals. It is in a completely different metabolic state. So the first question is not, how many calories does this patient need? The better question is, what is the body actually capable of doing with those calories right now? During sepsis, trauma, major surgery, or ARDS, the stress response drives inflammation, insulin resistance, proteolysis, lipolysis, and endogenous glucose production. Muscle is broken down to release amino acids. Those amino acids are redirected toward gluconeogenesis, acute phase proteins, immune activity, and tissue repair. At the same time, skeletal muscle becomes resistant to anabolic signaling. That last part matters, because it means that simply delivering more protein does not guarantee that protein will become muscle. The review describes data suggesting that critically ill patients may absorb amino acids adequately, yet incorporate substantially less of them into skeletal muscle than healthy adults. So when we give large amounts of protein early, we may be supplying substrate without actually reversing the underlying anabolic resistance. This is the mistake I think we make. We see muscle wasting and assume the immediate solution must be more nutrition. But muscle loss in early critical illness is not caused only by inadequate intake. It is being actively driven by the stress response. We often think we're feeding muscle. During the early acute phase, we may mostly be feeding a metabolic system that is not yet ready to rebuild it. That helps explain why aggressive nutrition trials have repeatedly disappointed us. Let's start with the route. Enteral nutrition remains preferred when the gastrointestinal tract is functional, not because enteral feeding has consistently produced a dramatic mortality benefit over parenteral nutrition, but because it supports the gut. It helps preserve epithelial integrity, tight junctions, mucosal architecture, immune function, and the intestinal microbiome. That biological rationale remains compelling. But we should also correct an old misconception. Early parenteral nutrition is not automatically dangerous. In patients with a temporary contraindication to enteral feeding, contemporary randomized trials suggest that short-term parenteral nutrition can be used safely without the major increase in infectious complications that many of us were taught to expect. So enteral is preferred, but parenteral is not a moral failure. The more important issue may be dose rather than route. Several large trials have shown that pushing full caloric targets early does not improve meaningful outcomes compared with restrictive or trophic feeding, and it can increase gastrointestinal and metabolic complications. That becomes especially relevant in patients with circulatory shock. In Nutriurea 2 and Nutriurea 3, patients receiving mechanical ventilation and vasopressors experienced more enteral feeding complications, including bowel ischemia, when full-dose enteral nutrition was started early. Many of those patients were receiving norepinephrine doses above 0.5 micrograms per kilogram per minute. I would be careful not to turn that into a rigid vasopressor cutoff. The review itself says the exact threshold remains uncertain, but the bedside principle is useful. A gut with compromised perfusion does not need a full feeding challenge. Low-dose feeding may be reasonable in selected patients on stable or moderate vasopressor support. Full-dose feeding during escalating or high-dose shock is a very different proposition. Now protein. For years, the logic sounded straightforward. Critical illness causes severe muscle loss. Therefore, we should give more protein. But larger trials have not shown an outcome benefit from very high protein delivery over more standard dosing, and there may be harm in patients with acute kidney injury. The review contrasts high-dose protein above 2 grams per kilogram per day with standard dosing at or below roughly 1.2 grams per kilogram per day, and concludes that aggressive protein delivery has not delivered the benefits we expected. Again, the physiology helps. Protein cannot force muscle synthesis when the patient remains profoundly inflamed, immobilized, and anabolically resistant. Later, during recovery, the equation may change. Once inflammation settles, mobility begins, and the patient transitions from survival to rebuilding. Nutrition and resistance exercise may become far more important together than either intervention alone. That phase distinction is probably where much of ICU nutrition has gone wrong. We've tried to use one prescription across completely different biological phases. The first days of shock are not the same as day 10 of recovery. What about feeding intolerance? Vomiting, regurgitation, diarrhea, abdominal distension, hyperglycemia, electrolyte abnormalities? These are common, but routine gastric residual volume monitoring is increasingly difficult to justify. It often interrupts feeding without clearly preventing aspiration or improving outcomes. A better approach is to look at the whole patient. Are they vomiting? Is the abdomen becoming distended? Is vasopressor support increasing? Is there evidence of ileus or ischemia? A number in a suction syringe should not replace clinical judgment. And finally, refeeding syndrome. This is one situation where the urge to catch up can cause real harm. In a severely malnourished patient, rapid carbohydrate delivery triggers insulin release and drives phosphate, potassium, and magnesium into cells. The result can be arrhythmia, respiratory muscle weakness, neurologic deterioration, and cardiovascular collapse. So nutrition should be started gradually in high-risk patients, with thiamine, electrolyte correction, and close monitoring. Not because calories are dangerous, because the metabolic transition is dangerous. The strength of this review is that it brings together physiology and contemporary randomized evidence. Its limitation is that nutrition trials remain messy. Patients differ in nutritional risk, illness severity, timing, baseline muscle mass, and recovery trajectory. A dose that is excessive for one patient may be inadequate for another, and we still lack reliable biomarkers that tell us when a patient has shifted from catabolism toward meaningful anabolism. That may be the most important unanswered question. Not simply how much to feed, but when the patient is biologically ready to use it. So what does that mean in practice? Start enteral nutrition early when the gut is functional, but advance it cautiously rather than racing toward full targets during the acute phase. Avoid aggressive feeding during unstable or high-dose vasopressor-dependent shock. Do not assume that very high protein delivery will reverse early muscle loss, particularly in patients with acute kidney injury. Use short-term parenteral nutrition when enteral feeding is genuinely not possible. Prevent refeeding syndrome, and stop treating gastric residual volume as the main measure of feeding safety. Early in critical illness, nutrition should support the patient without adding another physiological stress. As I was putting this episode together, one theme kept coming back. Medicine advances when we're willing to challenge assumptions, but not abandon them too quickly. The Transplant paper asks us to reconsider a contraindication that most of us have accepted without much debate. It doesn't rewrite the rules, but it reminds us that patient selection and tumor biology may be more important than a label like stage 4. The Treprostinil trials show something equally valuable. Not just a positive study, but reproducible science. 2 independent phase 3 trials arriving at essentially the same conclusion should give all of us more confidence that this isn't just another promising signal that disappears with time. And the nutrition review is a good reminder that physiology still matters. Before we reach for another protocol or another formula, it's worth asking a simpler question. What is the patient's body actually trying to accomplish right now? Sometimes understanding the biology changes our practice more than memorizing another guideline. If one of these papers changes the way you're thinking, or if you disagree with my interpretation, I would genuinely like to hear your perspective. Some of the best discussions happen in the comments after these episodes, and I've learned a great deal from many of those conversations. If you found this episode helpful, consider sharing it with a colleague, fellow, or trainee who doesn't always have time to read every new paper but still wants to stay current with the literature. Thanks for spending part of your week with me. I'll see you next week for another edition of This Week in Pulmonary and Critical Care Medicine.